Dorothy, and I'd like to sort of talk about your experience at your institution. You've mentioned to me before you have a really tough patient population with very, very high hemoglobin A1Cs, yet you're able to be successful in using EndoTool to manage those patients. Can you comment on your experience?
We tend to have well, not tend to, our community A1C is about 9.8 on average. We have some of the highest rates of U500 insulin usage in the Southeast in terms of our prescriptions. What we tend to see a lot of within our facility are mixed DKA HHS patients. So you'll see those high glucoses over, 1400, and you'll see them also have low bicarb gaps. And so we tend to see a lot of that. I think in terms of the changes that it's helped us a lot is our rates of hypoglycemia, especially since we have removed the bolus feature from our non-DKA order set. We have seen a significant drop in hypos, severe or just hypos less than 70s. In terms of, if you look at those numbers, our percentage of patients that are over the max meter reading is about 17.8%, or your customer average is about 7.4. So our patients tend to roll in with blood sugars over the 600s on average. And in terms of those that come in with their severe hyperglycemic range, that is the majority of our patients. We have frequent flyers that come in regularly that stabilize over a matter of like 12-ish or so hours because the program knows them and we've gotten to know them over their multiple trips. So yes, our patient population is fairly challenging, and EndoTool has made a very big difference in how we manage them and the hypothermia.
Yeah, it's interesting that you have so many patients that show up with a blood glucose greater than 600, more than twice as many as our customer average. And yet you still manage to have phenomenal results with very low rates of hypoglycemia and rates of hyperglycemia. So it's definitely an excellent outcomes that you're seeing, despite a rough group you're managing.
It is.
Another
Lots of COPD, lots of smokers, lots of steroids,
Lots of unhealthy people. As I mentioned in the introduction, you used EndoTool as a resident at Carolinas Medical Center when it was really early on in the early years of EndoTool. How did that impact your ability to care for patients as you were a trainee?
It helps them actually getting a little bit more confident with insulin drips. So at the time at CMC, they were doing a lot of liver transplants. They still do, but they were doing a lot more starting then. And with liver transplants, you have to maintain a fairly tight glycemic range. And I remember up until we started using EndoTool in its beta infancy, we were having to do the math to figure out what their drip rates were. And so we had a lot more hypoglycemia. And obviously, hypoglycemia can be just as detrimental as hyperglycemia, obviously. And I remember when we were around with patients that were on EndoTool, seeing how much less their hypos were in terms of rate and how quickly they were able to recover and actually come off of drips and go home in terms of their length of stay. It made a very, very large difference. And I think especially as a young resident who was already really nervous about insulin, and the training that I received, although we did diabetes, we didn't do diabetes. It's not a fellowship training by any sense. And so by the time I got the fellowship, I was still nervous about insulin, but a lot less because I got to use EndoTool. So I was very comfortable by the time I got to my program where they were using other drips. I was very comfortable with navigating that. I think EndoTool made a big difference there.
Excellent. Well, one comment I often hear from clients is that if they're using something like EndoTool or other insulin dosing software in a training institution, the trainees are not going to have the opportunity to really learn how to manage patients with a hyperglycemic crisis, for instance. Dr. Fleece, you're an academic institution. What are your thoughts on that? And has there been any pushback from your faculty to use such a tool for the residents?
I think early on when we were moving in this direction, this is around 2019, there were the comments like, residents aren't going to know how to dose insulin, but in reality, the residents didn't really know how to dose insulin that well anyway. And so when you have a tool that does it better than the resident, it seems that you really should, in the effort of good patient care, it only makes sense to use the best tool at your disposal. So I think the argument that, residents need to know how to accurately dose insulin. I mean, of course, when the EMR is down and all that, sure, that then it comes up. But for the great majority of time where we have all these tools at our disposal, you really should use the tool that gives you the best patient outcomes. So I think that's that's the argument I would say against the sort of concern about how good are our residents going to be at tweaking insulin drips. We're never that good at it, and this is better for the patient. I think that's how I see it.
How about Dr. Loy, Tracy? Any comments along that line?
I can start by saying I agree completely that insulin dosing is complex. And I'm going to date myself, but as a resident, part of my training, including doing sigmoidoscopies, floating swans, and doing other complex medical procedures that we no longer even train people to do because we feel they're specialized. I mean, I was the only person in the ICU at night changing vent settings. It's not exactly the same comparison, but in a way, if you look at complex, high risk medication, I think people need to know the basics. And I think they do learn by following what EndoTool's doing. Depending how you configure it, they have to make a decision to accept what EndoTool is advising, and certainly when they're transitioning off IV insulin. So we, as an academic medical center, had a little bit of concern about that, but now a couple years into it, the residents actually like it. They enjoy learning from it, and our endocrine consult service is getting consulted mainly for very complex patients instead of every DKA because the tool's managing it that well. And I guess that's my indirect way of saying I think this is the future. We don't go get maps from McDonald's to figure out how to get to the next city. We just tell Siri to take us where we want to go.
Oh, excellent analogy for sure. Tracy, anything you could add?
Only that we had a resident that went on to become an endocrinologist who's subsequently now practicing here as an endocrinologist. And one of the drawbacks was because he got to use EndoTool here, and he was very frustrated as a fellow that he didn't have access to it. But we don't, endocrinology does not come into the hospital anymore. Very rarely do they come in. Everything's managed outpatient now. And I think that's where, the endocrinologists are their best and they prefer to stay out there. And so I know from that perspective, the residents love it. They do get to teach and learn about it. And decisions are made jointly. If it makes suggestions, they're in collaboration with the attending. So, and nursing will always go with EndoTool. No matter what a medical resident says, a nurse will say, I think I trust EndoTool. So it is a great tool, though, to teach on. I do agree.
Well, thank you for that.